Brendon, thanks for joining us, and thanks everyone for joining today. I'm Dia Wagasback. I wanted to welcome you guys all to GlomCon. Today we have our partnership with the ERA, and I am going to introduce Dr. Kate Stevens, who's going to be moderating today's session. She's a consultant nephrologist at Queen Elizabeth University Hospital in Glasgow, and she serves as the chair of the ERA's Young Nephrologist platform. And she's been helping lead us in this panel and roundtable discussions we have. So I'll pass it over to her to introduce our speakers, and we'll get going.
Thanks, Dia. So I should confirm that I'm no longer young enough to be chair of the Young Nephrologist platform. So I stopped just earlier this year. So I'm delighted to be able to introduce this session today. So we're looking at new glucose lowering drugs and kidney protection in CKD. We have an eminent panel and an eminent speaker. So our speaker today is Dr. Brendon Neuen, who you may have just seen sipping coffee, and that's because I think it's 3 o'clock in the morning in Sydney. So we are particularly grateful to Brendon for coming to join us at such an early hour. Brendon is an academic nephrology registrar, and he has had a pivotal role in many of the multi-centre trials in this area, particularly Credence. He works at the George Institute in Sydney, and his research really focuses on the SGLT2 inhibitors. On our panel, we have Christoph Vanner, we have Maria Soler and James Boyle. Christoph and Maria are nephrologists, both of whom have an interest in diabetes and both of whom have played a role in some of these multi-centre trials. And Jim is a diabetologist, so we're delighted to have Jim join us today, and hopefully the predominantly nephrology environment will not be too frightening for him, and he can offer us some insight from a slightly different perspective. So without further ado, Brendon, I'll hand over to you.
Fantastic. Thanks very much, Kate, and thanks for having me, everyone. I'll just bring up my slides. Okay, fantastic. Well, thank you very much for the kind introduction, Kate. And sorry, apologies if my voice is a bit croaky. It is early in the morning here in Sydney, Australia, but thanks very much. I wouldn't miss an opportunity to join GlomCon and ERA EDTA to talk about such an exciting topic. So these are my disclosures. So I'm going to talk today mainly about SGLT2 inhibitors, but I'm also going to talk briefly about another class of glucose-lowering drug called the GLP-1 receptor agonists, which also have shown beneficial cardiovascular and potentially kidney outcomes in type 2 diabetes and their role in CKD. So initially, SGLT2 inhibitors were developed, we all know, were a class of glucose-lowering drug that were developed to treat type 2 diabetes, and they do so by lowering HbA1c, by increasing glycosuria and natriuresis, by blocking the SGLT2 transporter, which is expressed in the proximal tubule and is responsible for about 90% of glucose reabsorption. One of the hallmark features of these drugs is their effect on HbA1c, and their glucose lowering effect is highly dependent on GFR. And that's relevant for nephrologists because their efficacy in glucose lowering diminishes substantially as GFR declines and is substantially attenuated in the kinds of patients that we're likely to see in clinic. We could do a whole talk on the mechanism of action of SGLT2 inhibitors and how they protect the heart and kidney, but essentially you can think of them in terms of two main categories. They affect a number of cardiometabolic risk factors. They lower glucose, like I mentioned. They also lower blood pressure through effects on sodium wasting, but also effects on the sympathetic nervous system. They also lower weight loss through caloric losses and also lower albuminuria. In addition to these, and these are probably increasingly recognized as at least as important, is that they affect a number of cellular and physiological functions that are listed on the left-hand side of the screen here. And chiefly among these, they reduce intraglomerular pressure through the activation of tubular glomerular feedback and improve energy utilization efficiency, both in the heart and kidney. And these are thought to underpin some of their cardiovascular and kidney protective effects. It's been about almost 5 years now since Dr. Weiner, one of our panelists, first raised the hypothesis that these drugs may in fact slow the progression of kidney disease in type 2 diabetes. And I'm showing you here the GFR over time in EMPA-REG outcome and effects on doubling of serum creatinine, renal replacement therapy or renal death in the same trial. And since Dr. Warner presented those data at ASN several years ago now, there have been over half a dozen trials that have been conducted, enrolling over 50,000 participants now in an increasingly wide and diverse range of populations, from type 2 diabetes with atherosclerotic cardiovascular disease, to kidney disease, to heart failure with reduced ejection fraction in people with and without diabetes. And these trials have demonstrated substantial benefits on kidney outcomes as well as cardiovascular outcomes in these populations. I'm going to talk mainly about the two key kidney outcome trials, Credence and Dapa-CKD, which are listed on the right-hand side of screen. And I'm going to do that by comparing and contrasting them with the earlier cardiovascular outcome trials, the three early ones listed on the left-hand side of screen. If you look across these trials, they generally enroll people in the mean age was in their early 60s. They follow patients for between 2.4 and 4.2 years. And most of them had exclusively people with type 2 diabetes. But if you look at the mean GFR across the trials, it's in the 70s and even 80s in the cardiovascular outcome trials, and substantially lower in Credence and Dapa-CKD. And you can see only 7% of people had a GFR less than 60 in DECLARE, whereas almost 90% of people had a GFR less than 60 in Dapa-CKD. And then look again here at the UACR. Most people in the cardiovascular outcome trials have normal albuminuria, and look at the median UACR in Credence and Dapa-CKD, over 900. So these two populations in Credence and Dapa-CKD are the kinds of patients that we're likely to see in clinic. They are also at much higher, and that's because they're at much higher renal risk. And these trials were specifically designed and powered to detect effects on kidney outcomes. Another way to demonstrate the differences in the trial populations using the KDIGO heat map, you can see here the cardiovascular outcome trials primarily enrolled populations at low renal risk, which raised the initial hypothesis that these drugs may protect the kidney. But then when we look at Dapa-CKD and Credence, these enrolled people with higher levels of albuminuria, lower GFR, and in the case of Dapa-CKD, 1/3 of whom did not have diabetes. And this is a lovely figure from CKJ that also illustrates that same point. And you can see that comparing the populations to the pivotal renin-angiotensin system trials, Dapa-CKD and IDNT and RENAL, Dapa-CKD and Credence roughly sit in the same area in terms of the baseline level of albuminuria and GFR. So I don't think you can talk about SGLT2 inhibitors and kidney protection without talking about Credence. And that's because this was the first specifically powered and designed trial to detect the effect of SGLT2 inhibition on kidney outcomes. And what this trial did was, as you all know, it enrolled people with type 2 diabetes and an eGFR 30 to 90 and a UACR of greater than 300, and randomized participants to canagliflozin or matching placebo and followed them for a median of 2.6 years. All patients were required to be on maximum tolerated or labeled dose of RAS blockade for 4 weeks prior to randomization. And importantly, patients continued treatment with randomized treatment if their GFR fell less than 30 and until chronic dialysis or transplant was initiated. This is the Kaplan-Meier curve for Credence, and you can see here that canagliflozin clearly reduced the risk of the primary composite outcome of doubling of serum creatinine, kidney failure, cardiovascular, renal death by 30%, with a range of other beneficial effects on cardiovascular outcomes, including hospitalization for heart failure or cardiovascular death in this population. And this is important because we know that people with diabetic kidney disease are very high of both cardiovascular events and progression to kidney failure. And this was a substantial landmark trial for us in nephrology. When we look at the design of Dapa-CKD, it differs from Credence in a number of important ways. Again, the trial enrolled people with albuminuria, but it enrolled people with low levels of albuminuria. It pushed the UACR lower limit down to 200 from 300. It also pushed the eGFR, the starting eGFR, down to 25. And importantly, it enrolled people without type 2 diabetes. It excluded those with polycystic kidney disease, lupus and ANCA vasculitis, and those on immunosuppression prior to randomization, but had a similar primary outcome to Credence, that being sustained 50% decline in GFR, kidney failure, cardiovascular or renal death. There was a very important baseline characteristics paper that is published recently in NDT, which shows the breakdown of participants in Dapa-CKD. And as you can see here, approximately a third of people did not have type 2 diabetes. And of those, these patients had a range of different non-diabetic kidney diseases, including a reasonable number of patients with IgA nephropathy. And Professor Wheeler recently presented these results at ASN. And I'd be very interested to see more granular data on the effects of dapagliflozin in various populations without diabetes, which I'm sure will be reported over the coming months. As we all know, the trial was, both Credence and Dapa-CKD was stopped early for efficacy, which is remarkable for a renal trial. And here is the primary composite outcome. And you can see that dapagliflozin reduced the primary composite outcome by approximately 39%, with clear and statistically significant effects on cardiovascular, on hospitalization for heart failure or cardiovascular death, as well as death from any cause. Here is the effect on the primary composite outcome across clinically important subgroups. And you can see here, there is clear and separately statistically significant benefit for the primary composite outcome, irrespective of the presence or absence of type 2 diabetes. So we now have a treatment, dapagliflozin, an SGLT2 inhibitor that reduces the risk, cardiorenal risk in people without diabetes and CKD. So this is a really important advance for our patients and a fantastic breakthrough. When we look at the safety outcomes from Dapa-CKD, you can see that Dapa was generally well tolerated, and the incidence of serious adverse events like Credence was lower with dapagliflozin than placebo, and there were very few other serious adverse events indicating that the drug was well tolerated. I'd like to draw attention to the fact that there were no episodes of diabetic ketoacidosis in the dapagliflozin arm, and I wonder whether or not wonder whether or not the adverse events are different in people with non-diabetic CKD compared to diabetic CKD, and look forward to seeing that data published soon, hopefully. So, how does this compare to our current standard of care, and how do we contextualize the evidence across the trials? So I put together this forest plot a couple of days ago, and what this shows is the effect of SGLT2 inhibition on the most important outcome for patients, which is development of kidney failure, the need for dialysis, transplantation, or renal death. And you can see here the number of events in Credence and Dapa-CKD, by virtue of being renal outcome trials, is I think around 10 times more than observed in EMPA-REG outcome, Canvas and Declare put together. And you can see there's a clear and statistically significant effect on the incidence of kidney failure, with a 35% relative risk reduction, with no evidence of heterogeneity across the trials, and consistent benefits in Credence and Dapa-CKD. Put that 35% relative risk reduction into context by comparing it with Renal and IDNT. And you can see in these trials, RAS blockade reduced the risk of composite renal outcomes by 16 to 20%. So here we're seeing 35% risk reductions, almost 2 times that observed in Renal and IDNT. And this is on the hard renal endpoint of the development of kidney failure. So a substantial magnitude of benefit. And this is on top of RAS blockade. I think one of the most interesting stories about, or parts of the story about this class of drug, is that we were concerned that they may increase the risk of acute kidney injury by virtue of their mechanism of action and their diuretic effect. And that concern hasn't really been borne out in the randomized data. If you look at here, these are across all the trials now, and you can see there's a clear pattern of effect here, with a risk reduction for acute kidney injury of about 28% across the trials, Again, consistent benefit across the agents and trials, and diverse range of populations from heart failure patients in Dapa heart failure and EMPEROR reduced to renal patients to type 2 diabetes. And this is really interesting. I think many people have speculated about what the cause of this may be, and I wonder whether it's related to decreased energy expenditure in the proximal tubule. We know that sodium reabsorption through the basolateral aspect of the tubule is ATP dependent, and by blocking SGLT2 on the luminal aspect, these drugs may reduce energy expenditure in the proximal tubule and reduce the susceptibility of these cells to volume or ischemic related insults. But this is an ongoing area of investigation and one that I find very interesting. This is just a summary slide that demonstrates that these drugs in type 2 diabetes clearly reduce the risk of kidney outcomes that are most important to patients. And so this really represents a new era for us, I think, in terms of managing renal risk in people with type 2 diabetes. This does not include the most up-to-date data from Dapa-CKD. Many of you will know that the KDIGO guidelines recently released their recommendations on the management of type 2 diabetes and CKD. And there's now, based on the data that I just showed you, a class 1A recommendation for the initiation of SGLT2 inhibitors in people with type 2 diabetes and CKD, as long as their starting GFRs is above 30, based on the trials that I presented, noting that Dapa-CKD was not published at the time these guidelines were developed. And you can see here, this is a very nice flow diagram, again from Dr. DeBoer and the KDIGO team, showing that now SGLT2 inhibitors should be initiated as first-line therapy, along with metformin in people with type 2 diabetes and CKD, with the addition of other glucose-lowering drugs added after that based on patient comorbidities, preferences, and cost. And you can see here GLP-1 receptor agonists are the preferred next line therapy, and I'll show you why that recommendation was made. So I've been presenting to you relative effects, and I'm going to do that again here across the spectrum of GFR. These are data that we presented recently at ASN, and these are pooled individual participant data from Canvas and Credence across the full spectrum of GFR and albuminuria. Canvas enrolling people with higher GFRs and low albuminuria, and Credence enrolling lower GFR, high albuminuria. So here you can see this is the effect on the composite cardiorenal outcome of heart failure, MI, stroke, doubling of serum creatinine, kidney failure, cardiovascular, renal death. And you can see that actually there's a suggestion that the relative treatment effect actually increases as GFR declines. And whilst we're still exploring this effect further, it appears to be driven by a greater benefit for MI and stroke at lower GFRs. If you look at the effect across the full spectrum of UACR, you can see benefit even in people with normal albuminuria and a suggestion of increasing treatment effect or benefit in people with higher levels of albuminuria. When we look at the heart failure composite outcome, so excluding MI or stroke, you can see a very straight line there, consistent treatment effects across the full spectrum of GFR, including in those people with the GFR less than 45, in whom the glycemic effect of these drugs is essentially negligible, as well as a suggestion of higher benefit in people with higher levels of albuminuria, but still benefit in people with normal albuminuria. But those are all relative effects, and what I'm going to show here and what I really want to emphasize is the absolute risk reductions. And we know that people with kidney disease are at much greater risk of cardiovascular and renal outcomes, particularly those with high levels of albuminuria. And here I've displayed the absolute risk reductions per 1,000 patients treated over 2.5 years for the same GFR and UACR categories. And as you can see here, the absolute risk reductions for the primary cardiorenal composite outcome I showed you on the previous slide, they increase more than 5-fold across lower eGFR categories and almost 9-fold across higher UACR categories, with numbers needed to treat in the single digits for people with the highest levels of albuminuria and the lowest levels of GFR. And this really indicates that the patients that we're typically going to see in clinic are those patients who are likely to gain the greatest absolute net benefit from treatment. And so I think as a nephrologist, we've got a really important role to play in gaining the maximum benefit with these drugs. I'm going to talk briefly about where to next. We've presented a lot of very convincing data showing that these drugs protect the kidneys, but we still have understudied groups in whom the evidence is less strong at this stage. And I want to point out the important role that EMPA-KIDNEY has in generating new evidence for us. And hopefully this trial will be reported in the next few years. Credence and Dapa-CKD enrolled people with albuminuria, Dapa-CKD with a UACR greater than 200, but we have comparatively less data on the normoalbuminuric CKD patients, which are becoming more common, particularly normoalbuminuric diabetic kidney disease. And EMPA-KIDNEY really fills that evidence gap. It's going to enroll people with low GFRs with a starting GFR down to 20, and also include people with low or no albuminuria at all. And whilst the data I showed you was suggested benefit in people with normal albuminuria, most of those patients were people at higher GFR. So we really don't have a lot of data in this kind of level here, and that's going to be really important in the future. We don't want to extrapolate the evidence from Credence and Dapa-CKD to these populations. We want to generate evidence from those populations themselves. So EMPA-KIDNEY has perhaps the broadest inclusion criteria of any trial that's been conducted so far in the kidney space with regards to SGLT2 inhibition. As I mentioned, it will push the starting GFR down to 20. It's going to include substantial numbers of people with normoalbuminuric CKD, even more people with non-diabetic kidney disease. I think this is important given that only 1/3 in Dapa-CKD did not have diabetes. And it also permits the use of immunosuppression. And I think we have very little randomized data at the moment on whether patients on immunosuppression have a different benefit risk profile with these drugs because of mycotic genital infections. And this is going to be really important. And I look forward to seeing these results. In the meantime, this is a very nice analysis from Dr. Weiner looking at the analysis of EMPA-REG outcome, different DKD phenotypes. This non-overt DKD, normoalbuminuric DKD phenotype, which has been understudied compared to the Credence-like populations and cardiovascular outcome trial populations. And as you can see here, very promising data showing that the effect of empagliflozin in non-albuminuric diabetic kidney disease is consistent with those other DKD phenotypes. So look forward to seeing more data on this over the next couple of years. Finally, I'm going to talk about GLP-1 receptor agonists, which have been also discussed as a very promising avenue to protect the kidneys in type 2 diabetes. These drugs are mostly injectables, and they modulate the incretin system and have a number of effects that are listed here, and including increasing insulin sensitization, insulin secretion, and a range of other effects on a number of organs, including the kidney. They are much more potent glucose-lowering drugs, but they also reduce blood pressure and body weight, so improve cardiometabolic risk factors. And they may also have a range of direct effects on the kidney, including anti-inflammatory effects and reducing oxidative stress. In mediation analyses, looking at the effects of various GLP-1 receptor agonists on cardiovascular and renal outcomes, not all of their effects can be explained by reducing glucose, blood pressure, and body weight. So suggesting that there may be other direct effects on the kidney. Now, the data for the effects of GLP-1 receptor agonists on kidney outcomes is much less robust than for SGLT2 inhibitors. But what I'm presenting here is data from LEADER and SUSTAIN, looking at the effect of GLP-1 receptor agonists on total slope over time. And we know from the work that Dr. Inkler and the CKD EPI Consortium have published that total slope has been shown to correlate with effects on heart outcomes in large-scale collaborative meta-analyses. And as you can see on the top panel, semaglutide 1 mg versus placebo showed an improvement in GFR over time compared to placebo. And if you look at the bottom panel, liraglutide slowed the loss of GFR over time by over 1 ml per minute, with greater effects in both these trials in people with baseline GFR less than 60, suggesting that these drugs may have important benefits on the kidney that remain to be described. When we pull the data across the GLP-1 receptor trials, and I think this is really the crux of the issue, if you're going to remember one slide on GLP-1 receptors and the kidneys, this is it. The beneficial effects on composite kidney outcomes have been largely driven by reductions in albuminuria, which you can see on the top slide. When you take away reductions in albuminuria from the composite outcome, the risk reduction for hard outcomes or creatinine-based kidney outcomes is much less clear, and emphasizes that we still have some uncertainty about the beneficial effects of these drugs on the kidney. And but this favorable suggestion of benefit is why GLP-1 receptor agonists are considered the preferred next line therapy after SGLT2 inhibitors in the recent KDIGO guidelines. And it's been given a 1B recommendation here. There is, because of this uncertainty about the kidney benefits of GLP-1 receptor agonism, there is currently being conducted a dedicated renal outcome trial called the FLOW trial to test the effect of semaglutide versus placebo on a primary kidney outcome of sustained 50% decline in GFR, kidney failure, cardiovascular, renal death. This trial is enrolling people with type 2 diabetes and CKD with high levels of albuminuria if you have a GFR greater than 50 and a lower degree of albuminuria if your GFR is 25 to 50, and results are expected in the next couple of years. And this will be really important data as we clarify what is considered standard of care for people with type 2 diabetes and chronic kidney disease. So I've touched on these topics, but where do I think that the data and trials are going next? Well, EMPA-KIDNEY is looking at pushing the starting GFR as low as 20 mils per minute and generating evidence in normoalbuminuric CKD and more evidence in non-diabetic CKD. We still have little data on kidney transplant recipients, and I think this, along with understudied populations such as those with lupus or other non-diabetic kidney diseases, will be really important going forward. The role of combination treatment strategies with GLP-1 receptor agonists and finerenone is important to clarify. In lieu of head-to-head trials, I think if the FLOW trial enrolls enough patients on baseline SGLT2 inhibitors, that will be important and give us really useful data. And of course, we know that there is a gap between what we know in randomized trials and what is actually implemented in clinical practice. And part of this is due to financial reimbursements in many different settings. And I'd be interested to hear what those are from some of the participants today in other settings outside of Australia. And I think there is a real role for implementation science. We know that these drugs work. We need to be able to get them to the people who would benefit most, and dedicated research to improve implementation, I think, is going to be an important field, not just in SGLT2 inhibitors, but really in nephrology in general. So finally, in summary, I've shown you data that shows that SGLT2 inhibition is a safe strategy for reducing the risk of kidney failure in people with chronic kidney disease, including in those people without diabetes in the Dapa-CKD trial. These drugs are coupled with substantial cardiovascular benefits, particularly for heart failure. And those people with more advanced CKD, lower GFR, higher UACR are those who stand to gain the greatest net clinical benefit from treatments. GLP-1 receptor agonists have favorable effects on composite renal outcomes, but these are largely driven by reductions in albuminuria, and the effects on hard renal outcomes remain to be determined in the FLOW trial. But for now, we can say with certainty that combination RAS blockade and SGLT2 inhibition should be routinely offered to people with a high risk of CKD, and in the case of dapagliflozin, in those people without diabetes. Thank you for your attention this morning or evening, wherever you are, and very happy to take part in the panel discussion now.
Brendon, thank you very much. That was an excellent run through and a great set of slides and a terrific summary of everything. So can I just pick you up on your last point? So from a practical perspective, So normally with ACE inhibitors or angiotensin II receptor blockers, we would check kidney function sort of 10 to 14 days after they're initiated or after dose titration. So with the SGLT2 inhibitors, we know there's a dip in GFR. So it's really two questions. Would you recommend that renal function is checked after these are initiated? And the second part is, if you see, depending on the dip in GFR that you see, does that have any implications for the efficacy of these drugs? Does it offer us any insight into how well they will work in an individual?
Yeah, so that's an excellent question, and one that that we're increasingly thinking about. When we looked at, I've got some slides here anticipating that someone might ask that question. So we know that, and I should also mention that Dr. Warner has also done a similar analysis of the EMPA-REG outcome, and I'd be interested to hear his comments on this topic too. So we know my practice is similar to what was done in Canvas and Credence. So in Canvas and Credence, participants came back at week 3 for a GFR check, and you can see that's the first data point on the GFR slope slide above. And so I check kidney function routinely at about 3 to 4 weeks after starting an SGLT2 inhibitor based on the Credence trial. In Canvas, that was 6 weeks or even 12 weeks in Canvas, and 6 weeks in Canvas R, but I think 4 weeks is reasonable based on the Credence trial, and you'd expect an initial dip in GFR based on the mechanism of action of these drugs. As you can see here in the lower panel, about half or just under half of people experience a greater than 10% decline in GFR in those who received canagliflozin in the Credence trial. And what I'm going to show you here on the next slide was presented by Dr. Heerspink at ASN last month, which shows GFR over time in the canagliflozin and placebo arms according to their initial GFR drop. Purple being an increase in GFR, blue being a small decrease in GFR, and green being a larger acute dip in GFR. And as you can see here, the slopes across those 3 categories are similar. Oh, sorry. Regardless of the initial dip in GFR, with similar results for safety outcomes as well. So I think, and I should make a caveat that these data are not randomized, so they're not as robust as the other things that I've shown you. But I think we can say that so long as the GFR dip is less than 30%, that these drugs are safe and effective, equally effective at lowering renal risk.
Perfect. And Crystal, sorry, on you go,
But more detailed data coming out in this space. Dr. Warner, did you want to have any comments on that?
Actually, we have our, let's take this. We have our paper in press in Kidney International. We did not break the randomization, but in essence, it shows the same data. It's a little bit more pronounced, the dip here in the Credence than in EMPA-REG outcome, but more or less it's the same. I'm not worried because it stabilizes.
I have a question for you, Professor Warner. So when did you recommend to your patients the control after starting SGLT2 inhibitors?
Sorry, Maria, when do I recommend, what was that again?
When do you recommend the control after starting SGLT2 inhibitors in a patient with 45 milliliter minute GFR, for example?
We're missing a word, Maria. When do you recommend the what, sorry?
The control, the next visit, the next control, the creatinine.
I see.
All right. Yeah, so 3 weeks, Maria, is what was done in Credence, and I typically bring people back 3 to 4 weeks, expecting an initial dip in GFR. And so long as that is, less than a 30% dip in GFR, I'm not particularly worried, and it's probably a sign that the drug is effective in reducing intraglomerular pressure.
I have a different position. Brendon, excuse me, Crystal. When we bring these patients back, it makes it a bit noisy. And I'm working currently with on the EMPA reduced and the totality of evidence in EMPA-REG outcome. And I try to identify the patients who really dip and what happens there. And if you look at all this and after some digestions, we maybe can come to the consensus you don't have to remeasure creatinine, just treat your patients and go on. And this is currently among the cardiologists very welcome, this message and the data, because it makes much more easy, and we don't have to wait 10 years before we overcome the dip which we saw in RAS blockers and remeasuring. That's my position. It's
Christoph, I don't disagree with you. My position is like what I've stated is I think a bit more conservative based on what was done in the trials when they were brought back. But if you look across all the trials that have been done in renal and looked at individual participant data, many treatments that protect the kidneys have acute effects that differ from their long-term GFR effects. And for a lot of interventions, there is a lot of individual variability in that initial change in GFR across that cannot be accounted for by the intervention, the disease state, baseline GFR and UACR. And I'm working with CKD Epi looking at how the acute effect, what the magnitude of acute effect across different interventions are across the different trials. And so, I kind of agree with you that there is a lot of variability in that acute effect. When we show you when we present the very dramatic eGFR slope curves, it suggests that we should check it early, but at an individual level, there is substantial variability. And, about on that last slide that I showed you, about, a quarter of patients actually increase their GFR initially when they start an SGLT2 inhibitor. So I don't think it really is a cause as much for a cause for concern as potentially made out to be. So I don't disagree with you.
And I want to move on to a different topic, but I guess the problem with checking the GFR, if you see a dip and somebody's on ramipril, for example, is you might find that ramipril gets stopped or the SGLT2 gets stopped. And so I guess the German approach of turning a blind eye is maybe the way forward. Okay, so can I change tack slightly and bring our diabetologist into the discussion? So Dr. Boyle, who I work with in Glasgow. So Gemma, I wonder, obviously the recommendation currently is that metformin is still first line for the most part, and then if it's not tolerated, we switch to the SGLT2 inhibitors. I think the European Society of Cardiology recommend SGLT2 as first line, but I wondered what your thoughts were about that and how you see that in practice. So do you have a lot of people who are on the combination of metformin and SGLT2 inhibitors, or are you having a sort of fairly low threshold to change people over to an SGLT2 inhibitor?
Yeah, and I think certainly current clinical practice would be, first line metformin, although that is beginning to change in certain patient groups. But often when someone's started metformin, then provided they tolerate it, we would then add in an SGLT2 inhibitor in the context of type 2 diabetes. And obviously that's for glucose lowering. But there is a kind of, in terms of those who initiate these drugs, certainly in the UK, it's primary care physicians, and the guideline changes are still really to take effect. So although the primary care physicians in the UK are becoming much more comfortable initiating SGLT2 inhibitors, second and third line, the message in terms of selecting patient groups to initiate it first line is still to get through, and that's going to take some time, I think. Part of that has got to do with it does take longer to counsel a patient you're starting on an SGLT2 in terms of the potential things to look out for, and also for those patients who are starting with a more elevated hemoglobin A1C, the risk of, say, mycotic infection is higher, and in some cases, actually bringing their glucose down, even temporarily with, say, for example, a sulfonylurea, might be an approach before then instituting an SGLT2 inhibitor. And I think that's one thing just for my renal colleagues who are on the webinar, is just having that think about what the hemoglobin A1C is at baseline. So for those people who you would like to start an SGLT2 inhibitor, if their hemoglobin A1C is less than 60, for example, and they're on sulfonylurea and or insulin, then it's likely that the risk of hypoglycemia is relatively high, and that it's likely that you need to modify their coexisting oral hypoglycemics, at least initially on initiation.
Okay, so what target HbA1c would you aim for, or would you be happy with in a renal patient with some proteinuria and let's say a GFR of 45? Where would you go with your HbA1c?
I think in terms of initiation of an SGLT2 inhibitor, I think something less than 80, you feel relatively comfortable. But if it's greater than that, then having a conversation with your friendly diabetologist to see whether another option to bring down the hemoglobin A1C, and at least initially, would be favourable, whether that would be insulin, whether that would be even a GLP-1 receptor agonist as well, because it has a more profound, generally will have a more profound effect on glucose lowering. Even oral semaglutide has been shown to be, which is now getting a license here in the UK, has been shown to be superior to our range of SGLT2 inhibitors.
Yes, I'll just move to Brendon, who's put a slide up. But I guess maybe the combination, or the best combination for these patients is metformin, an SGLT2 inhibitor, and a GLP-1, if they can tolerate all three, and an ACE inhibitor. Brendon, did you want to talk through the slide that you've just popped up?
Oh, no, just really I completely agree with James. I think those are very sensible, practical points. And I often work in consultation closely with endocrinology colleagues when I'm uncertain about what to do about their glucose lowering drugs, mainly in people who, as James said, are either already on insulin or they're on a sulfonylurea, and they've got reasonable kidney function. So this is more important if their GFR is higher, like GFR greater than 45, because you're going to add on some A1C effect with the SGLT2 inhibitor. And so these are recommendations from KDIGO to potentially, in some patients, if they're achieving their glycemic targets, to pull back on other things to facilitate the addition of an SGLT2 inhibitor.
Okay, perfect. I'm conscious that we've got lots of questions on the chat, but I guess from a very practical perspective, how are you all going about initiating these drugs in your patient populations? So in Glasgow, for example, we have done a search of our electronic patient record to try and identify patients who we think an SGLT2 inhibitor might be appropriate to prescribe in, and then we are trying to catch these people when they come to our clinics. I'm aware that in other places, people are being contacted. So rather than waiting for patients to come, they're proactively contacting patients. What are you doing in Germany, Spain, Australia?
You see, I usually decide, do I need an organ protective treatment or do I don't? And I'm not looking at hemoglobin A1C anymore when I go for an indication of an SGLT2 inhibitor. You see, we are now getting all these indications maybe for IgA nephropathy or non-diabetic heart failure, non-diabetic kidney disease. And there is absolutely no danger about lowering an hemoglobin A1C or not lowering by 0.2. So organ protective treatment is my way of thinking in the moment.
So I guess what I was meaning was, are you, so now we have all this wealth of evidence that SGLT2 inhibitors are a magic bullet and basically everybody should be on them. Are you proactively identifying patients to start them on, or are you just waiting until you see them in the clinic? Maria?
Actually, we are waiting when we see them in the clinic, but we used to see them in the clinic every 4 months. So I have the opportunity to visit them.
Okay.
And a part of that, we are doing a lot of talks to the primary care. So we are going to talk with people from the primary care and show them the beneficial effects. And actually, there are a lot of people involved in diabetes in primary care. So in Spain, I have the feeling that the majority of the patients are already, when they came to my consult, in SGLT2 inhibitors. And now I'm starting, not now, 1 year ago or something like that, I started to give them agonist GLP-1. And it's easier because we used to recept we used to recept anemia treatment. So for us, it's easy. The subcutaneous injection is not difficult to show the people how to use the drugs. And there's one thing really important. We are not seeing a lot of hypoglycemia with these two drugs. So I used to feel comfortable with them.
Okay. And Brendon, are you identifying patients, or are you just waiting until they come to see you?
Yeah, again, just waiting until patients are seen in clinic. You know, I think there is a role for implementation science research to see how we can increase the uptake of these drugs to people who need them most. But certainly at this stage, kind of doing it in an ad hoc fashion when patients do come in. But increasingly, I think primary care are recognising the beneficial effects of these drugs on end organ protection, at least in Australia. Part of the challenge for us is that although I completely agree with Christoph that, you know, we should be thinking about what is the goal, which organs are you trying to protect and in whom. The prescribing restrictions in Australia are still largely based on glucose control. So that's how these drugs are subsidised on the pharmaceutical benefit scheme. So we require in Australia patients to have an A1C of greater than 7 and be on either metformin or some other glucose lowering agent, or not receiving them if they don't tolerate it for GI intolerance for metformin, for example. But it still limits our ability to prescribe these drugs in some patients in whom they would clearly benefit.
So we've had lots of questions on the chat, so I'm just going to put some of these to you if that's okay. So unsurprisingly, there are questions about the use of SGLT2 inhibitors in other types of glomerulonephritis, so particularly IgA nephropathy, given that Dapa-CKD had more patients with IgA than any of the IgA trials. What are your thoughts about the SGLT2 inhibitors in IgA nephropathy? Would you prescribe them?
Yeah, I mean, I guess for me, the question is, I mean, if I were a patient with IgA nephropathy, would I take it based on what David Wheeler presented last month at ASN? And I think, you know, if any of us were, ask yourself, if you were a patient with IgA nephropathy and you saw the data from that David Wheeler presented, would you want to be on this drug? I think all of us would say absolutely. Of course, there are different IgA is really heterogeneous. We know there's lots of different histological findings, different patterns of renal function loss. And so interested to see more data in that respect. But I think you can make a very compelling argument based on the data from Dapa-CKD that if you were treating a patient with IgA nephropathy, you'd start them on dapagliflozin if they fulfilled the inclusion criteria of Dapa-CKD.
Yeah, I think that's
I completely agree with him. Sure, after the data from the ASN, for sure.
Yeah, absolutely. What about SGLT2 inhibitors in transplant recipients?
Yeah, I think, you know, this is really hard to say for certain in either way, because the patterns of kidney function loss are different. You've got different drivers of renal injury, rejection, antibody-mediated rejection. The potential relative benefits and harms might be different in people on immunosuppression. So I think it's really hard to say. I know there are case series and small observational data from single centers showing that these drugs are protective, but I don't think we've got clear randomized evidence to say one way or the other. Interested to hear what Christoph thinks on this topic.
At least for sure, we need randomized clinical trials on that topic. I think that if you know the companies, and we think that we need that, no, in transplant patients and maybe in hemodialysis patients. We don't know the mechanism.
No, and I guess GFR below 30, but that's coming, isn't it, from that's ongoing work.
Yeah, that's right. And should note that in terms of that starting GFR, Emperor reduced is enrolled people down to a GFR of 20. So we've got Dapa-CKD, GFR down to 25, Emperor reduced down to 20, and Emperor Kidney, which is coming down to 20 as well. So those are good points, Maria.
Yeah, just creeping down. So Jim, we obviously have in nephrology stolen one of your drugs. So I'm going to put this question to you, since I'm guessing you've got most experience with it. So lots of questions about the side effects of the SGLT2 inhibitors. So amputation, diabetic ketoacidosis, genital infection. And there's also a question wondering whether or not SGLT2 inhibitors might influence renal stone formation. So I wonder if you could comment basic, I guess, on your clinical experience about the side effects and what you should counsel patients against.
Yeah, I mean, obviously patient education here is hugely important, as is patient selection as well. The good news for my colleagues in the world of nephrology is that these medications are really well tolerated in general. So while there are small risks of volume depletion, genital mycosis, and particularly euglycemic decay, that the risks are small and I think are mitigated with, as I said before, patient selection in terms of making sure that someone would be able to discontinue the medication if they had an intercurrent illness, or if they were planning an operation, for example, around decay and volume depletion, and obviously to ensure that they're up to date with their monitoring of their examination of their feet, etc. So I'm not aware of any relationship or any evidence to support a relationship between SGLT2 inhibitors and stone formation, unless anyone else has seen evidence to support that. Certainly not something I've encountered in my own clinical practice. And I think one of the positive things around the type 2 diabetes CKD story is that for things like genital mycosis and risk of hypoglycemia and people on concomitant sulfonylureas and insulin, is that actually that group of people who are in between EGFR of 30 and 45 actually have a low risk, and it's the group that's kind of 45 to 60 that Brendan's mentioned are the ones that obviously you counsel everyone on these risks, but are at a higher risk of having problems.
Thank you. Yeah, I'm not aware of any effect on stone formation. I don't know whether Brendon, Maria, Christoph, you have any comment about that?
No, nothing to add from me. I haven't seen any particularly compelling data about the effects on kidney stone formation with these drugs. There may be some small reports, but nothing robust that I've seen.
Okay, and then so one of the groups of patients that got missed from some or maybe even all of these trials are patients with vasculitis. So a question on the chat asking if a patient who has, let's say, a vasculitis and is in remission but has residual proteinuria, would you think about using an SGLT2 inhibitor?
Yeah, I mean, good question. We're pushing the envelope a little bit with these kinds of patients. I personally, if they didn't, to be strict to the trials, if they weren't included in the trials, we don't know for certain in terms of what the potential relative benefits and harms are. But I think there is a role to study these patients in a randomized fashion, the kind of patients that weren't included in Dapa-CKD and won't be included in EMPA-KIDNEY, and those people, those kind of, like the patient that you suggest is certainly worth studying. I have, your guess is as good as mine, I think, at the moment.
Yeah,
I think the same. It's a really interesting question, and I think that there is a kind of anti-inflammatory protective effect that could be also positive in these kind of patients.
Yeah, absolutely. Okay, so I want to quickly ask just one more question, then I want to ask Jim and Maria about GLP-1 inhibitors, because I know that both of them are involved in the FLOW study. So essentially, the question on the chat is, when do you think in the evolution of CKD we should start an SGLT2 inhibitor? So I guess by that, if somebody's got proteinuria and a normal GFR, should we start an SGLT2 inhibitor? If somebody's got a bit of renal impairment and not much proteinuria, when should we start the SGLT2 inhibitor? My understanding, I guess, is as soon as somebody's got diabetes, they're on metformin, maybe their control's not great, they've got a bit of proteinuria. I think if it was me, I would want canagliflozin or dapagliflozin. Do you have any comments from your clinical practice about when you would look to start these?
Yeah, certainly. I think if people have albuminuria at any stage of GFR, even if it's at a higher GFR, I think you can make a very strong case for starting SGLT inhibitors. I think the sensible way is to just identify, what's their renal risk according to the KDIGO heat map. And if you look at higher GFRs with albuminuria, those people at very high risk of renal and other adverse events. So you certainly, if people have albuminuria and normal kidney function, they should receive treatment. even looking at, I think in the specific case of type 2 diabetes, if you've got type 2 diabetes, GFR greater than 30, and you've got normoalbuminuria, I still think these patients probably benefit from treatment both in relative and absolute terms, because we know even low GFR in the absence of albuminuria in type 2 diabetes is associated with poor outcomes, and these patients derive benefits from treatment too. So I think, and that's data that has been shown by Christoph and in that diabetes, obesity, metabolism paper, and in the EMPA-REG outcome and canvas analyses by KDIGO risk category. So I think anyone who you think is at risk of kidney disease should be treated with these agents, essentially, if they can access them.
I will ask a little bit more, and we go to every diabetic patient, because the DECLARE goes as a primary prevention. So if there is no money problem, maybe every diabetic patient will need that, or will have a benefit of that. This treatment, I don't know. But.
Yeah.
And Jim, are you doing the same? Because I guess you're probably the only person here who sees the most patients with diabetes with a normal in inverted commas GFR. So are you following the same lines as Brendon in terms of when you start these?
Yeah, very much so. And I think I would say that the diabetes community are very much in consensus about that approach in terms of how Brendon's described. So yeah, and I think the reality is that for a whole host of reasons, we're going to be in a situation, I suspect, in many ways that we won't know why someone got onto an SGLT2 inhibitor. It could be for more than one reason. But we're not precious about these drugs, but we've kind of accepted that maybe glucose lowering isn't their biggest selling point anymore.
No, we've stolen them, haven't we? Okay, so then we're almost at time. That's been a terrific discussion. But let's just so GLP-1, we Brendon, you touched on them briefly, and I guess you made the important point that we essentially don't know how good these drugs are in terms of renal outcomes, because we don't have any hard data. But Maria and Jim, you're both involved in the FLOW study. Do you have any comment about that? Do you have the patients that you've enrolled in the study? Maria, I guess first of all, have you noticed from clinical experience and from your study involvement whether or not you're seeing any benefit?
I didn't have the opportunity to check at the patients, because we enroll 8 patients now. But with the patients in my, not the FLOW ones, the ones that I'm giving already the therapy, the semaglutide, I don't have secondary effects. The only thing that they have is that they are not that hungry, that they cannot eat much, but this is a benefit if in these obese diabetic patients. Yeah. So let's see the FLOW. I'm waiting for the results to the FLOW, but we will have to wait at least 1.5 years, 2 years to know what's going on with that. But I have good feelings at that moment.
And are you noticing a reduction in the proteinuria or albuminuria?
There are 8 patients. I don't know which one. I didn't check.
No, I mean in clinical practice, when you use a GLP-1, do you notice any difference?
I notice the loss of weight.
Loss of weight.
Yes, and this is important, at least 7 kilos. But we have that COVID that came here, and people is not moving so much. So we will need 1 year to see what's going on with the proteinuria.
Jim, are your patients getting thinner if they're on a GLP-1?
Yes, I mean, obviously we've got just a small number of people in the FLOW study, but yeah, we know the benefits that the GLP-1 receptor agonists bring, more profound glucose lowering, and again, for the patient groups is again looking at their concomitant medication, whether they need to maintain on some of these hypoglycemia-inducing medicines. The other thing about the GLP-1 receptor agonist is that actually the data for stroke reduction is actually better than SGLT2 inhibitor. I think that's a benefit. So I think recruitment ends for the FLOW study kind of beginning of next year. So we wait the results eagerly.
Okay.
They're published. I think the other thing to say is the combination of SGLT2 inhibitor and GLP-1 is a very promising one. Yeah. There's a question about type 1 diabetes, and obviously SGLT2 inhibitors are licensed in type 1 diabetes for glucose lowering, and people with certainly in the UK for a BMI greater than 27. And one of the things is that the risk of diabetic ketoacidosis in this group, and patient education is a big part. There is some evidence that the concern, or one of the reasons why they increase the risk of ketoacidosis is around increasing glucagon, and we know that the GLP-1 receptor agonists reduce glucagon, and the effect of them in combination might be something that's quite an attractive one for a whole host of reasons. And indeed, we've got a study called Triple T, or triple therapy in type 1 diabetes that we're about to start soon with John Petrie in Glasgow, and also Brendon Neuen in New York, and that's looking at type 1 diabetes and the combination of SGLT2 inhibitor dapagliflozin and semaglutide, and that'll be interesting to see whether you get the benefits but also offset the risk in the type 1 population of ketoacidosis.
We need to watch this space and have somebody design one pill with all these beneficial effects. So I've got 2 points before we wrap this up. So the first I'm going to put to Christoph. So in terms of the cardiovascular risk reduction that we see with the SGLT2 inhibitors, is the magnitude of that similar across all the groups? So across patients with CKD, type 2 diabetes, heart failure, or do you see a difference?
While it's so easy to answer it with the kidney, which is so consistent, the cardiovascular is more variable. We still discuss the baseline risk of the patient with multiple risk factors. More or less the different risk. Overall, we try to introduce the class effect. When we look at Vertis and the investigators who interpret Vertis, they say more or less it's quite consistent with the point estimate left of unity, and they do not want to discuss these variation around. Yeah, okay, that's
good. That's great. Point. Thank you. And then the very last point, so I guess it's 2 points. So the first is patients who are on diuretics. Are you counselling patients about the diuretic effect of the SGLT2 inhibitors and modifying the diuretic regime? And then the second part of that is, are you providing patients with sick day rules? So are you modifying their diuretics if they're on them, and are you giving them specific sick day rules? So Jim, do you do that in your diabetic patients?
Yeah, I have now pretty much experience in EMPA Kidney, where I pushed 150 patients now to treatment in the study, and my clinical behavior is moving towards the elderly when you ask me these questions. Yeah, they walk into town, they want to see where is the toilet plan. When they are on diuretics, an additional diuretic, and the sick day rule, it harms usually, or the elderly above 75 biologic, chronologic needs more of this advice than the younger one. That's my clinical experience.
Okay, so do you ask them to stop the SGLT2 inhibitors if they're unwell?
Yes, I ask them when they go into elective surgery, when they have these sick days. Actually, my colleagues in anesthesiology are pretty good to stop for 3 days perioperatively the SGLT2 inhibitor. So I accept this.
Okay, Brendon?
Yeah, very similar in practice for me too. You know, the anaesthetists are very, at least in Australia, very cognizant of the potential risk of ketoacidosis around the time of surgery, and you know, certainly I tell patients if they're undergoing surgery to stop treatment within 48 hours or so before major surgery, and also when they're unwell, yes, I do give sick day advice.
And Maria, the same?
It's the same in Spain, and also they have diarrhea or something like that, or fever, so we recommend them to stop for 2-3 days. The same in Spain.
And Jim, are you the same?
Yeah, I mean, you can't reinforce this enough. I mean, I think it's still under the radar. I think we could be doing better at it. I think it needs to be reinforced at every clinical contact. And in type 1 diabetes, we've got a nifty protocol called STITCH, which is stop your SGLT2 inhibitor, take some insulin, take some carbohydrates and hydrate. But one of the things that the important difference between the type 1 population, type 2 population around ketones is that people with type 2 diabetes don't routinely check their ketones, whereas people with type 1 do, and they're given education to self-manage. So I think that kind of enforcement of that advice around people who have got an elevated hemoglobin A1C, who are on insulin, who have got type 2 diabetes, who are not routinely monitoring their ketones, is even so more important.
Yeah, absolutely. Okay, so on that note, let's wrap things up. So thank you very much to our panelists. That's a fantastic discussion. And Brendon, that was an absolutely brilliant talk, particularly given 3 o'clock in the morning. I hate to see what you can do at a civilized time. So thank you all very much, and thank you to everybody for joining us. The session will be on YouTube later if any of your colleagues want to catch up with it. Okay, have a nice day or evening, wherever you are.
Thank you, Kate.
Take care.
Yeah.
Thanks, everyone. Thanks for having me.
Thank you.